A 35-year-old man with the cholesterol levels of almost 7 millimoles per liter and with a history of almost 30 packs of cigarettes per day. If compared to a woman with no history of smoking and with normal cholesterol levels, what is the risk factors that he or she may develop the atherosclerotic phenomena or atherosclerotic diseases? If compared in these two scenarios, the male are more predisposed to the development of the atherosclerotic diseases as compared to the females. The other risk factors that are associated with the development of the atherosclerosis is obviously the history of cigarette smoking. So one of the primary risk factors is the smoking is one of the primary risk factors over here. On the other hand, the cholesterol levels are also calculated to make the person more prone to the development of this atherosclerotic diseases. So what is atherosclerosis? How do you define this pathological phenomena which is known as atherosclerosis? It's basically a progressive inflammatory disorder in which there is the focal deposits of the lipids in the intimal walls of the arteries. What is the fate when these intimal walls are filled up or they are lipid-laden? What is the final fate for this lipid-laden macrophages that are present in the intimal walls of the arteries? Either these arteries can be completely blocked after this lipid-laden macrophages or after these fatty streaks have been developed in the intimal walls of the arteries, or either there can be a disruption, erosion, ulceration, fissuring phenomena observed in these atherosclerotic plaques that are present over there, basically making these atherosclerotic plaques of the unstable kind. After they have become the unstable kind, there can be these fatal complications, for example, hemorrhages, aneurysms, that have to be encountered, obviously. Atherosclerosis on a whole, it can manifest clinically in different scenarios. Three basic or the three major categories for the clinical manifestations of the atherosclerosis. First of all, we have the coronary artery diseases, which can be basically the angina. We can have the unstable or the stable kind of angina, or either it can be the myocardial infarction, which can obviously subsequently result in the sudden death of the individual. Then on the other hand, we can have the cerebrovascular diseases that are also observed in these individuals. Now, what is the fate of these cerebrovascular diseases? It can be the stroke that is observed in these individuals. It can be the transient ischemic attacks that are also experienced by these individuals who have basically these atherosclerotic processes carrying on or carried on into these central nervous systems of the bodies. On the other hand, if there is the peripheral vascular diseases, the peripheral vascular diseases are basically manifested clinically as the intermittent claudications, or either there can be the critical limb ischemias observed in these individuals. Now, again, this is the emergency states that can arise due to the cerebrovascular diseases, or either it can be the coronary artery diseases, and on the other hand, we have the peripheral vascular diseases as well. So usually the patient, if they present to you in the outpatient department as the peripheral vascular disease patients, they have to be investigated for some sort of an atherosclerotic diseases as well, or some sort of an atherosclerotic processes that are being carried out in the body, or there is some sort of a pathology that is underlying behind these intermittent claudication that the person is giving you a history of. So this is the clinical picture that is usually seen, and the investigations, obviously, they're very important, ranging from the primary investigations of the vitals, of course. When you take the vitals of such patients, for example, it can be the pulse rates, it can be the blood pressure of the individual, the respiratory rates are again very important over here. These are the vital examinations that have to be carried out. And then obviously, we're going to further more go into the laboratory investigations of these individuals, ranging from the LDL levels, the cholesterol levels of these individuals. The family history has to be taken in detail as well. The socioeconomic history is very important. The patient particulars are very important. The age, the gender of the individual, as well as the family history. Now, talking about the genetic predisposition of the atherosclerosis basically is very important over here. The patient would usually give you a history of any close relative who has been suffering from atherosclerosis, either the parents, either the siblings. So taking the history is again very important. As your risk factors, we divide them into the fixed risk factors as well as the variable risk factors of the individuals. When we talk about the fixed risk factors of the individuals, it can be the age, obviously, then we move on to the gender of the individual, and then finally move on to the genetic predisposition or the family history of the individual as well. And then the variable risk factors that can be present, for example, the history of smoking, the hyperlipidemias, hypertension, diabetes. All of these are again very important. Dietary components are again very important over here. The consumption of alcohol is again very important. Sedentary kind of lifestyle is again making the person more prone to the development of this phenomena, of this pathological basis, which is known as atherosclerosis over here. So these are the primary and the secondary risk factors that we have to consider whenever we have a patient of atherosclerosis over here. So basically, this is what we're going to discuss over here, is the pathological basis of atherosclerosis, and we're going to finally discuss this over here. This is basically a diagram which is showing you the inflammatory mediators being deposited in a particular area due to the activated endothelial cell lining. And then finally, what happens is there is a fat layer that is deposited in the internal walls of the arteries that is going to basically stenose the arteries, basically hindering the arterial supply to a particular area that the artery is basically supplying. And then finally, this stenosis can be critical enough, or there can be a complete thrombotic occlusion that can result after this thrombus formation, or either there can be the embolization of the thrombus in the vessel. So these are the different fates that can be encountered after this process of atherosclerosis. It starts on within a particular vessel in a body. Talking about the preclinical phase, so it can be an asymptomatic phase as well as, on the other hand, it can be a symptomatic phenomenon of atherosclerosis. Obviously, in the earliest forms or in the earliest phases, it is basically a preclinical phase that is observed, and it is usually asymptomatic in the individuals. Usually, the young age group is affected by this preclinical phase. Postmortems carried out in the accidental cases or in the traumatizing cases, they even documented individuals in their second or the third decades of life, and they are being reported that the vessels were in the process of the formation of the atherosclerosis phenomena. So it can start off as early as second and third decade of life if there's obviously a familial or a genetic predisposition. And then finally, the symptomatic or the clinical phase, it starts off usually in the 6th, 7th, or in the 8th decade of life. It is only then that this diseased process is basically found to be more symptomatic. So this is known then as the clinical phase of the atherosclerosis over here. As you can see, we have the normal arteries. There is no fat deposit in the internal walls of the arteries till now. And then we find that there is the formation of this fatty streak over here That is basically a slight formation or the slight lipid formation over here in the intimal walls of the arteries. Now, what is basically making this portion or this intimal wall more prone to the development of the fatty streak formation? What are the lesion-prone areas for the thrombus formation? What are the factors that are responsible for this thrombus formation is again very important. Obviously, this phenomena is accelerated by the risk factors, as we've already emphasized on this fact that these risk factors can be basically divided into, first of all, the fixed categories, that is basically the primary risk factors, and then finally, we have the secondary risk factors over here. The primary risk factors would basically consist of the age, obviously, then the male predisposition towards the formation of this fatty streak formation is more predominantly present over there, and then the genetic predisposition. So the genetic predisposition, the family history is very important to take from the patient, because that is going to highlight whether the patient is predisposed genetically to this process of atherosclerosis or not. Then we have the secondary risk factors. The secondary risk factors, they basically start off from the lifestyle of the individual. Now, this is quite debatable because the sedentary lifestyle is basically shown to be more prone to the development of this process of atherosclerosis. Then we have the history of smoking. Then there is the history of alcohol consumption. Then there are some of the dietary factors that are also very responsible for the development of atherosclerosis. It can be the less intake of fruits and vegetables, a lot of vitamins, if they're not taking in the right appropriate amounts, that can make the person more prone to the development of atherosclerosis, that basically or mainly include vitamin A, D, and E. And then we have the obesity. It's one of the risk factors as well. The increased cholesterol levels, the increased LDL levels, they are again making the person more prone to the development of atherosclerosis. These are some of the risk factors. Then there are some of the diseased or the systemic correlations as well. For example, hypertension, or if the person is suffering from diabetes mellitus. So these are the history takings that have to be emphasized upon whenever you are taking a history or a detailed history from a patient in which you're suspecting that he or she is suffering from atherosclerosis. The endothelial dysfunction, obviously the activated endothelial is the terminology that has been used in the books just to say or just to highlight the fact that the endothelial is not functioning in the proper manner. This endothelial dysfunctioning or this activation of the endothelium is basically going to recruit the monocytes towards the intimal or towards the intimal lining of the arterial walls. Now, when these monocytes are recruited towards the intimal walls, what basically happens is the monocytes are adhesive. The adhesion molecules, they become activated, and as a result, these monocytes, they are adhesive towards these intimal walls, and finally there's an emigration phenomena. The inflammatory cells are immigrated towards the intimal walls. The cytokines are released, of course. There are a range of cytokines that are released when the monocytes are migrated towards this phase. It can be the tumor necrosis factor, it can be the interleukin-1, we have the interferon gammas. So all of these mediators, these inflammatory mediators, they play their role towards this immigration of the monocytes towards the intimal walls of the arteries. The smooth muscle cell migrations to the intima is again very important. When we basically overweigh this monocyte, as on the other hand, we have the smooth muscle cells. The monocytes, they play an inflammatory role in this process of atherosclerosis, and on the other hand, These smooth muscle cells, they play a repair role in this phenomena. Basically, their contractile function is not the highlight over here. Their repair role is more important over here. So whenever this balance is not maintained in the atherosclerotic process and the inflammatory process or the monocytes, they overpower these smooth muscle cells, the atherosclerotic plaque is going to become unstable. So this stability is very important, to have the monocytes and on the other hand to have the smooth muscle cells to form that fibro-fatty capsules that is basically covering the atherosclerotic plaque over here. The smooth muscle cell proliferation is again very important over here. These smooth muscle cells basically they start to proliferate in the outer walls of the fatty streak. What basically happens is they're forming the fibrocapsule over here. Right over here, when the fatty streak is going to increase in size, they're going to basically form a protective covering on the top layers of this fatty streak. Then we have the ECM elaborations, that is basically the extracellular matrix that is going to be elaborated over here. What are the components of the extracellular matrix? When you ask yourself, the answer is going to be the inflammatory cells, then the cytokine mediators. All of these are going to be increasing in size whenever this progressive atherosclerotic process is going to take place. Then we have the lipid accumulation on the other hand, because the internal walls are going to have these monocytes which are going to be converted into the macrophages that are basically the lipid-laden macrophages, and they're also known as the foam cells. So this is the phenomena that is basically taking place, or this is the whole pathological basis, that is the process that is occurring whenever this atherosclerosis is taking place. Then we have the complete formation. After all of these events have taken place, we have a complete fibroflatty plaque that is present over here. You can see the extracellular matrix has increased in amount. You can see the fibrous capsule has been formed by the smooth muscle cells. And you can see that the interleukins, the cytokine mediators have basically formed the lipid-laden macrophages, and the lipid has been deposited in the intimal walls of the arteries. So this is the process by which the intimal walls of the arteries are laden or loaded with these lipid content. Now, what basically happens in the advanced stages of this fibrofatty plaque formation? What are the characteristics that are basically going to make this fibrofatty plaque more prone to the development of the advanced stages of the disease? First of all, the cell death and degeneration. Now, after the cell death and degeneration, what is basically going to happen is this atheromatous plaque is going to transform into a more unstable entity. The inflammatory process is going to increase, and finally what is basically going to happen is the plaque growth is going to occur in this phenomenon. Obviously, after the plaque growth, there is going to be a stenosis of the arteries, the arterial supply or the blood flow to that particular vessel or to that particular organ that the artery is supplying, that is going to be hindered. Either there is going to be a complete thrombotic occlusion. On the other hand, there can be the remodeling of the plaque. Now, what is the remodeling of the plaque? It can be basically divided into a positive remodeling, and on the other hand, we can have a negative remodeling of the plaque. What are the factors that basically make the artery or go towards the positive or go towards the negative remodeling of the plaque that are basically not known, that is idiopathic in nature, but still we can say that if there is a positive remodeling of the artery is going to increase in size after this atheromatous plaque formation. And if there is a stenosis of the arteries, then it is basically the negative remodeling of the artery, or the lumen of the artery is going to be stenosed in the negative remodeling of the plaque. So these are the two consequences that can occur. The etiology is not known for this remodeling of the plaque, of course, and then the wall of the arteries, there is the extracellular matrix is going to increase, and then finally the organization of the thrombus is going to be seen in this phenomena. The organization of the thrombus is such that there is a fibrofatty plaque formation that is basically going to form a protective covering, and as I've already emphasized, on the inner side, on the inside, there is going to be those monocytes that are basically lipid-laden macrophages or the foam cells. Now, on one hand, we have that a protective covering that is basically provided by the smooth muscle cells, and on the other hand, we have the inflammatory process. So whenever there is a disbalance between this inflammatory process and the repair process, and the inflammatory process overpowers, then there is going to be the formation of an unstable plaque. And on the other hand, we can also experience ulceration, erosions, fissuring of the plaque. That is again going to make the process, or that is again going to make this atheromatous plaque more unstable in its form, or either it can be calcified. So these are the different fates of the atheromatous plaque formation that can be overviewed over here. Obviously, all of these phenomena, when we say that there is an inflammation, plaque growth, plaque rupture, erosion, remodeling, or either there is a calcified formation of the atheromatous plaque, it's basically an advanced or a vulnerable plaque that we're talking about. What are the characteristics that we can identify a plaque to be vulnerable? It can be an increased extracellular matrix. It can be a thin fibrofatty capsule that is present over there. Increased lipid has been deposited. These are the characteristics that is going to make the plaque, or that is going to highlight that this plaque is basically now unstable or a vulnerable plaque that can embolize at any time, or that can basically cause a complete thrombotic occlusion at any time. So these are basically the characteristics of a vulnerable plaque that we have to focus on. And these characteristics have to be focused on whenever, because these can basically contribute towards the complications of the atheromatous plaque formation, which we've already discussed. It can be either a cerebrovascular accident, it can be a coronary artery disease, resulting in a sudden death, or either it can be a peripheral vascular disease resulting in a critical limb ischemic condition, which is again an emergency. So these vulnerable plaques have to be looked for whenever we have these atheromatous plaque formation in process. Having discussed the preclinical phase, or having discussed the asymptomatic phases of the atheromatous plaque formation, now we're going to discuss the clinical phases. Usually, these clinical phases, they are encountered in the 6th, 7th, or in the 8th decade of life. So this is the phases of life in which we see the symptoms that are associated with the atheromatous plaque formation. Mural thrombus formation and embolization can be one of the consequences, can be one of the complications that can obviously happen after there is an unstable plaque, after there is the plaque rupture, after there is a plaque erosion phenomena, ulceration phenomena, hemorrhage or aneurysms can result. Wall weakening is one of the phenomena that we've already discussed in the remodeling phenomena, or in the remodeling category. That is basically the complications or the consequences of the atherosclerotic processes. Now, after this mural thrombosis, after this embolization has occurred, embolus can obviously result in a transient ischemic attacks of the cerebrovascular accidents, and can basically hinder the blood supply that is hindered due to this phenomena of the atherosclerosis. Aneurysms and rupture can be one of the resulting factors that can happen after this wall weakening, embolization, or mural thrombosis phenomena. On the other hand, we have the plaque rupture. And finally, we have the plaque erosion phenomena that is seen in these cases. Now, whenever we say there is a plaque rupture phenomena that is happening in this particular case, what are the causative factors towards these plaque rupture? It can be the smooth muscle cells that are basically forming that particular fibrofatty streaks. And then we have these crux formations that are basically going through and through the plaque and that are either not present or that have weakened off, that can result in a plaque rupture in a particular case or in a plaque erosion in this particular case that we're talking about. Then we have the plaque hemorrhages on the other hand. And finally, we have the mural thrombosis. Mural thrombosis is basically a complete arterial occlusion that takes place after the thrombus has grown enough that it has completely occluded the lumen of the arteries. So that is basically causing the mural thrombosis over here. And then finally, it can result in the embolization after there is a rupture, after that thrombus is dislocated through the contractile function, and that is basically being dislodged into the circulation. It can basically occlude the artery if it goes towards the capillaries. It can occlude the arterial supply towards the artery. So it's again very important over here. It can obviously result in the occlusion by the thrombus. So these are the particular complications of the atherosclerotic plaque formation, and that can also be termed as the advanced stages of this particular disease that we're talking about right now. Obviously, on a clinical note, we'd be seeing an aneurysm. On a clinical note, we'd be seeing a hemorrhage or a completely occluded artery. But the pathological basis would be this complete sequence of events that we're talking about time and on over here. So it can be a progressive disease as well, and we can obviously correlate with this factor that this phenomena of atherosclerosis is basically a progressive inflammatory disorder. It won't stop once it has started, so these preventive factors have to be discussed and have to be emphasized upon whenever you have a patient of atherosclerosis or whenever you are suspecting that this patient has some ongoing process of atherosclerosis in his or her body. So you have to educate the patients accordingly for primary prevention and then finally the secondary prevention for this particular disease. When we talk about the primary prevention, obviously, it can be the risk factors that are more educated to the patients, and the patient is more well versed with what are the different lifestyle modalities that can basically help him from not developing this progressive disease. You can educate the patients that these risk factors which are fixed, we cannot deal with them. For example, if a person is born by the genetic predisposition, or if he or she has a family history, obviously that cannot be changed. The age and gender of the patient cannot be changed. But obviously the factors which are modifiable, that can be looked for, and that can be basically maintained to get a better lifestyle and to modify the lifestyle of the individual to basically prevent that particular person from developing that disease. So usually the plaque growth that happens in the most advanced stages of the disease, and that we have to focus on and that have to be prevented in people who are more prone to the development of this particular disease. The critical stenosis is what we are going to face in this particular case. So these are these particular combinations that we are going to focus on the horizon or in the complicated stages of the atherosclerosis, and we have to focus on these stages as well. The aneurysms and ruptures have to be taken upon, the occlusion by the thrombus has to be taken upon, and then the critical stenosis is one of the factors or one of the complications as well, and it has to be looked for to prevent the person from developing these advanced stages of their diseases. You have to educate these individuals towards these processes, towards these pathological processes. When you're working in the outpatient departments or in the clinics or even in the wards, and you go or you come across patients who are more prone to the development of atherosclerosis, you see basically an obese individual, male gender, history of smoking, history of alcohol consumption. The dietary changes are not observed in these individuals. He or she has a family history of development of the atherosclerosis and is suffering from the high cholesterol levels. All of these are going to make the person more prone to the development of atherosclerosis. So the education of the patient or the awareness regarding this atherosclerotic process is again very important over here, that we've already gone through in detail. So do watch the other lectures for the pathological basis of the other phenomena on sqadia.com. Thank you.